Thanks everyone for coming. So today was just a quick overview on the HINTS Plus exam. Just a little bit of background for those who haven't met me. My name's Cameron Kealy. I'm an osteopath just down the road from a lot of you at 324 Queen's Parade. I'm an osteopath and I've done a whole bunch of postgraduate training on things to do with heads, a lot of cranial technique, a lot of courses overseas, migraine courses, and that's kind of weaved its way into post-concussion courses. Then the logical stuff with treating a lot of migraines was that we were getting a lot of dizziness, vestibular migraines, and with concussion, there's a lot of vestibular rehab, and so we've kind of moved into the vestibular rehab component as well. So we spend a lot of our day seeing things like vestibular neuritis, vestibular migraine, and BPPV, which are all dizziness presenting complaints. And in the course of the training, I became aware of the HINTS Plus exam, which I graduated 25 years ago. It's something which has popped up well and truly past my uni days, and so I just thought it was a good thing to be sharing around, because it's particularly for any primary care practitioner who's going to be seeing dizziness. It just gives you another tool that can potentially be a really handy thing for differentiating something which might look like a stroke, or it might look like something else, but just gives you another tool that you can put in for that situation of, is it a stroke or is it a benign vestibular migraine or vestibular neuritis. And yeah, so just our bread and butter is, just for a bit of background, is we're treating a lot of headaches and migraines. On average, we're getting about an 80% reduction in headache and migraine frequency for most people. And the problem with a lot of manual therapy that we've discovered over many years of doing this is that we have this, we have this connection between the upper three cervicals and the brain stem, this cervico-trigeminal tract here. And treating this area can help with a lot of dizziness presentations, and in particular headaches and migraines. And the problem with a lot of approaches is they just treat locally, and what we found is that we found techniques where we can treat anteriorly, superiorly, and inferiorly, and that gives us that much better result with a lot of these problems. So anyway, so that's a bit where we come from. But tonight we're just getting onto the HINTS Plus exam. So the learning objectives of this this quick overview is just differentiate the HINTS Plus is to help you differentiate between a central lesion in dizziness or a peripheral lesion, so out in the vestibular apparatus, out in the peripheral, in the middle ear. And so we just want to look at the HINTS exam and just put manual therapy, physical therapy in the context of that. And of course, the most important thing is someone comes in and so they've got a central lesion, got a stroke, got to go straight to the emergency department. Peripheral lesion, we can obviously, you can manage that if you're a GP with your medication, but the suggested therapy of choice is vestibular rehab, manual therapy. Now, hopefully you've all seen that. We delivered a slightly more extended version of that, and it's just the HINTS exam spelled out so that you can have it as a reference. But it's, having been teaching stuff before, it's very hard to just go to that and not have it explained beforehand. So that's what we're doing. That's the point of today. So a bit of quick background. So the HINTS exam was first published in 2009, which, as I said, for a lot of people, that's after they've graduated from uni, so it's kind of new. And the big kicker for this one is that it was shown, I can just quickly, 100% sensitive and 96% specific for stroke. And this line here is the big one. Initial MRI imaging was falsely negative in 12%. So basically the HINTS exam in the first 48 hours was shown to be more sensitive for stroke than getting an MRI, which is, it's obviously the gold standard for stroke usually. So it's good that not only can, in primary practice, you can stop referring people for MRIs that they don't need, but you can actually be more sensitive than the MRI with this very simple little exam. And then in 2013, 4 years later, they I'm not even going to try and pronounce the name. Oh, hang on, Newman and Toker, updated it a little bit, and they found that if we added the hearing test, we went from looking for a central lesion, sensitivity was 96% for the HINTS exam, but if they added a test for hearing, which is the HINTS Plus, it became 99.9%. So we went from the HINTS exam to the HINTS Plus a few years later. Yeah, and so it gives us this really good sensitivity for picking up strokes, as you see. Now I've just stuck this up here. I've relied on Peter Johns here for presenting this. Peter Johns is a emergency physician. He's just retired, but he's got years of videos and videos and videos on the HINTS exam, on dizziness, on BPPV. So we're going to lean on some of his videos for this presentation. And if you wanted to look into this more, you will not find a better resource anywhere than his YouTube channel, where he has video after video talking about this kind of stuff, and he's published journal articles and the like. So he's a fantastic resource if you want to look into this a bit more. Okay, so jumping to the overview, and I've actually got the background of this from Peter Johns, because not being a primary care physician, if someone looks like a stroke, I'm immediately going to refer that out. So the first step is, when do we use the HINTS Plus exam? So the definition that we use is the acute vestibular syndrome. And the acute vestibular syndrome has 3 criteria. The first one is that we have a sudden onset of vertigo, and it is lasting, very importantly, hours to days. So if someone has BPPV, it's, they might turn their head when they're in bed. Often they're, excuse me, they're turning their head in bed, or they're getting out, and they'll have acute dizziness for a short period of time, maybe, minutes, and then it will get a lot better, and they might have a little bit of queasiness, but the bad dizziness resolves really quickly. In the acute vestibular syndrome, like you might see with a stroke, sorry, I'll just grab some water. Sorry about that. We have hours to days of dizziness. The person says, oh, I've got nausea, vomiting, and they have an unsteady gait. So they're looking really red flaggy, like this person's had a stroke. They've got bad gait, they're dizziness. And the important criteria, once again, I got this really clearly from Peter Johns, is that they need to have nystagmus at rest. Sorry about that, just go back. So that's the presentation that we're looking at here. And so if we have that presentation and we go, oh, is this a stroke? Do I want to get this person out of here? Or do they just have a benign vestibular neuritis? 99% of the time it's going to be a benign vestibular neuritis, but there is a chance it could be a stroke. So how can we differentiate between those two things? So the first thing is to rule out a stroke as you would usually work that out. And I've just put in here, as per your complete medical education, because as I said, generally speaking, if I was getting anyone that was having a stroke, I would be referring that out to someone else based on the criteria, as I said, that I'll get from Peter Johns here, is that we've got new significant, if they have any of these, new significant headache, weakness, paresthesia, facial droop, double vision, difficulty speech, dysmetria, which is cerebellar symptoms, touching finger to nose, all the cerebellar tests, and we've got it here, difficulty walking unaided, which is one step up from difficulty and unsteady gait. That's, if they can't walk without someone else, get out of here. And so if you're a GP, that's going to be your bread and butter. So I'm not going to talk any more on that, but it's just a reminder that the HINTS Plus doesn't take out everything that you already know, and you would just look for all of this other stuff as well. And if this is all clear, then we can go, okay, let's have a look at the HINTS Plus exam and see if we've got an underlying stroke here. All right, so HINTS, as I hope I didn't actually say it, but HINTS is head impulse test, nystagmus, and test of skew. HI, let me just go through, and TS. So that's the acronym that we're using. And the head impulse test, this is the foundation of the HINTS exam. And what we're doing is we're getting the patient's head and we say, okay, so look at my nose, and what we want to do is we just want to move the head backward and forward a little bit and just say, okay, so I'm just going to move your head backward and forward a little bit, and then we're just going to do a quick movement, and it's about 30 degrees to one side, so it's not like 90 degrees or anything, but we just want a short, sharp movement. And it's got to be fast. And so things that you don't want to be on the TMJ, you don't want to be wobbling down here, you want to be on the head, and you don't want to be slow and sluggish. If you can think of it, if you were teaching it, you might say, okay, it's got to be like a, internally it's more of a, it's like it's like you might brace your core to. You want to get a little bit of speed in it, because if you don't have the speed, you won't see the catch-up regard. And what we're looking for, we've got a little diagram here, but we've got the patient looking at our nose. We quickly turn their head, and what will happen is their eyes will lag and they'll lose contact with your nose, and then they'll correct and go back. And that's called a saccade. And if they have that, that's a good sign. That is a sign for a peripheral disorder, and it's going to be vestibular neuritis. If you go into the studies, there is a 2% chance that it could be labyrinthitis, but either way, it's benign. You can send them home. They don't have a stroke. And so if we see this, we go, you can breathe easy and go, okay, this looks like vestibular neuritis. We're probably pretty safe here. However, there is a couple of catches. One, if they've got a pontine stroke, or if they have a blockage of the anterior inferior cerebellar artery. I did check it today because I always forget that one. That's going to take out the vestibular cochlear nerve, and so you will show up as a peripheral problem with any of those two strokes, which is why we have the test of skew, which shows up the pontine stroke, and we have the plus. We have the hearing test, which will show up that anterior inferior cerebellar artery stroke blockage. So anyway, so that's the overview. Now let's actually have a look. What does this actually look like? Now, so there's Peter John's page. Check that out if you want more information. Okay, so this is just the first one. We're going to have a look at just what nystagmus looks like in this patient. So we're going to have a fast phase and a slow phase. Okay, so let's just quickly go through that again. Okay. Yeah, we have the okay, so most of the time, the patient's going to come in, they're going to be acutely dizzy, having trouble walking, they've said, I'm nauseous or I've thrown up, and you're going to look at them and they will have that nystagmus. They'll have that sitting there. However, there are cases where sometimes the symptoms might have eased a little bit. As I said, I'm constantly referring to Peter Johns. He gives an example of someone who had bad symptoms the day before. They were on the ground for a couple of hours and then they got up and they were feeling a bit better. And so the nystagmus might have faded, and so it's hard to see. So what you can do is you can take out fixation from their eyes and hold up a piece of paper and just ask the patient to look 30 degrees to the left. And because you've taken out fixation, the nystagmus can be more prominent. So that's just a little trick that he's thrown in there, that if you can't see the nystagmus, that you can just hold up a piece of paper, take out the fixation, get them to look through the paper, and then the nystagmus, as we saw in the video, might just start to show up again. And so that's just a little trick for if the patient doesn't have the nystagmus. As I said, usually they will. If they don't, you can just check it, just stress test it and see if it's actually hiding in there. All right, so Actually, back to the window. Okay, and now we've got the head impulse test. So this is normal. This is a positive head impulse test, and this is what it should normally look like. There we go. So I'll just do that again, because this is the crux of the whole test, is being able to do this head impulse test, and seeing that catch up card, and I have seen a few, and it is quite noticeable when you get one. Going back far enough. There we go. All right, so we'll just do it again. So notice the speed and normal one way. There. All right. Cool. So that's the head impulse test. All right. So, okay. So that's the head impulse test. So HINTS, HINTS exam. So the next thing is nystagmus. Now, as you've seen, the person's going to have nystagmus. When you say, so the next test is say, look to the left and look to the right. And so once again, it takes like what, 5 seconds, 10 seconds. So this is really quick. It's taken a long time to explain, but it's really quick when you do it. So just look to the left, look to the right. The nystagmus should not change direction. So if it changes direction, get them out, because they're having a stroke. So the nystagmus should always go to the ear which actually has the problem. So we can just quickly go to the video. We've got a video of this as well. Okay, so this is a stroke. Okay, we see that? So the nystagmus changed direction when we look left and right. Look to your left, look to your right. Oh, changes direction. Okay, get out of my office. Don't want to see you on an ambulance. That's a negative, and I think, was this the positive? So yeah, so this is normal. There it goes. It goes the same direction. All right. So I'll just do it again, because these things are quick. So this is normal. It's going left. And the fast beat still goes to the left. All right, so that's your N, HIN. And so now we've just got test of skew and the plus. So the test of skew is simply, I won't go back to the slide, but it's just to cover and uncover the eye, like so. And what we don't want is any vertical repositioning of the eye. So let's just, while we're here, we'll just look at this. And notice that it goes horizontal, but it goes up, and this one goes down a little, up and down. And I think it might be better if I just go to the slide here. So this is one of my patients, and this, when I first started, this really threw me because I didn't know what this meant. If you have a look, the eye goes really horizontal. So I was looking for any change. See that one, it went a little bit medial, and that there's a pronounced medial movement on that. Now that is normal. I didn't know this at the time. I didn't know what was going on. That's a normal adaptation to vision being blocked one side to the other. I think it's not optimal, but that is normal. And if you just have a look, I'll just play it again. Look how horizontal that movement is. It's a beautiful horizontal movement. That one, just beautiful horizontal, lovely horizontal movement. But if we go back to this one over here, Okay, so once again, I'll just make sure we're at the start here. It goes up. It's not a pure horizontal movement. That one goes up, and this one goes down. Let's do it one more time. That one goes. Yeah, so it's diagonal. All right, so if we see that, get out of here, they've got a stroke. And this one's pretty easy. Just finger rub. Can you hear it? Do you have any hearing loss? And that is the HINTS exam. Took a little bit longer than I was planning on to get that through, but that's the gist of it. All right, so the bottom line is, so we need, if you have a look at the handout down the bottom, it's got vestibular neuritis is diagnosed if all of these four are present. One, abnormal head impulse test. So we've got the catch-up card. It's like, cool. And we're negative for all of those other things. If any of those other things are positive, get them out. And that's the basic gist of it. So I've just chucked in a case study. Oh, here we go. So I'm just going to read it through. Okay, so our case study, we have a 45-year-old lady presents with constant dizziness since last night. They feel nauseous and have difficulty walking. Is that acute vestibular disorder? Yes, it is, because difficulty walking, and they've had the dizziness for several hours. Okay, they have nystagmus beating to the left at rest. Okay, we needed that. So because they've got nystagmus, we can do the HINTS. We do the head impulse test. Test is positive to the right. Great. That's a great sign. That looks like it's probably vestibular neuritis. And we're probably going to be able to send them home. But we just got to do the rest of the exam to check if that's a false positive. And so we do the there we go. I finally got it back. There it is. Okay, head impulse test positive. So we look at nystagmus. Does the nystagmus change direction? No, it doesn't. Test of skew is normal. Hearing is normal. Diagnosed vestibular neuritis. Send off to recharge the vestibular rehab if you would like to send them here. But the bottom line is they're not having a stroke because by diagnosing vestibular neuritis, you've basically ruled out a stroke by diagnosing, the vestibular neuritis. All right, case study 2. 60-year-old man whose dizziness suddenly comes on after getting out of bed 4 hours ago. So he's had it for 4 hours. That's really important. If you got out of bed and it lasted for, a couple of minutes, the room started spinning and then it stopped, that's probably going to be BPPV. But if it's constantly bad for 4 hours, stroke, vestibular neuritis. These are the two big ones because it's maintained. And he's having difficulty walking and he's vomited. So we can use the two that we've said. So we have a look, he's got nystagmus. Okay, cool. We can do the HINTS. We have a look, head impulse test, negative. We don't get a catch-up card. Okay, this is a little bit concerning. Nystagmus changes direction when he looks left as to when he looks right. Okay, what's that mean? Get out. I don't want you in here. This guy's had a stroke. He's had a pontine stroke because it's. Actually, no, we don't know. Sorry, jumping ahead. Test of skew is positive. Okay, so from the test of skew, we know that the stroke is in the pons. No new hearing loss. Diagnosis is a pontine stroke. Get him out of here. All right, so that's the HINTS exam. If anyone wants me to drop by the office of anyone there, and we can just go through it, and we can just make sure that you're getting the speed on the head impulse test, because the head impulse test is the important bit, because that's what we're trying to get a positive sign on the head impulse test, and then just check there's no false positives by going through the rest of the test. All right, so that's it, guys. Now, if anyone needs to go, please head off. I've already gone over time. But I was just going to chuck in here, if anyone's interested, I was just going to give a quick case study of how we look at migraines, because we've just got a point of difference there. So if anyone needs to go, have a great night. But if anyone wants to hang around, I'll just quickly go through one case study on our on how we go about migraines. So this is just someone I saw a little while ago, 41-year-old female, daily headaches, migraines every 2 weeks. And she's been like this since 15 years, since she's had a car accident. So, you could argue that there's a bit of post-concussion in here, but the presentation is daily headaches and migraines. Only thing that she got relief from was Botox every month, and she was having protein every day. And I'm not a doctor, but I'm thinking that's not a great thing to be having every day. So she tried like everything. Preventive medication didn't work for her, massage, acupuncture, physio, chiro, different pillows, different beds, and nothing really changed it. And so what we did is we had a look at that upper neck, and she had a lot of tension from the jaw, from the fascia around her head. And after 3 sessions, headaches and migraines had stopped. So just to go back here again, migraines once every 2 weeks, headache every day for 15 years. And after 3 sessions, it had cleared up. Now, why did that clear up when she's had physio, she's had chiro, and massage? And it's just because of all this other study and stuff we've done, is that we found that upper neck, it's influenced from above, below, anterior, and sometimes the tightness, you need to get the tightness where it is to get the pressure out of the upper neck. Now, she went 6 months before getting another migraine. Statistically, it's a 95% reduction. Diagnosis was that the upper neck was the problem, but I've said cranial fascial tension here, but the muscles and fascia around the jaw, around the skull, were still knocked around from the car accident, and that's kind of what we need to do. So I just threw that in there just as a bit of a background on our bread and butter. That's what we're looking for. So if anyone has any headache or migraine patients that I think that would be helpful for, by all means, send them through, and we'd be happy to keep you updated and it's what's been happening. So anyway, thank you. Just Mike left. Mike, thank you for your time. And
Cameron, it's really helpful to hear your pitch on the migraine, and really grateful to join in the section today. Amazing.
Excellent. Yeah. Fantastic. Alrighty, guys, I'll let you go. Have a great night, and I'll see you later.